Good afternoon. I'm Heather Young, professor at the Betty Irene Moore School of Nursing at UC Davis. And with Tom Nesbitt, I'm co-champion for the Healthy Aging in a Digital World initiative, and have worked closely with CITRIS Health for over a decade. I'm happy to be here with you today. Welcome. We're really happy that you're joining us for the 14th year of the CITRIS Research Exchange Seminar Series. We've hosted a remarkable lineup of technology innovators in person at Sejalia Dye Hall and are glad to see all of you joining virtually today for the Spring 2022 series. Today, we're joined by Holly Jimison, and I am so delighted to be introducing her to you today. Dr. Jimison is the director of the Consortium on Technology for Proactive Care at Northeastern University and on the faculty in both the College of Computer and Information Science and the College of Health Sciences. She leads a multidisciplinary, multi-institutional effort to facilitate research in the area of home monitoring of health behaviors, including helping researchers address the challenges of big data related to large amounts of complex and noisy streaming data from multiple sources used to infer clinically relevant health behaviors. Her current research projects are focused on technology approaches to support healthy aging. I first met Dr. Jimison when we were both professors at Oregon Health and Science University, where she made a large impact with her work on technology for successful aging and scalable remote care. She's a highly sought advisor and thought leader, and is currently serving as visiting professor at UC Davis, working on the Healthy Aging in a Digital World initiative. What you don't see on her CV or her website are her personal qualities of having a brilliant mind, a generous spirit, and the ability to bring people together around ideas. So it's my great honor to welcome her as our speaker for the CITRIS Forum today.
Wow, thank you, Heather. That is amazing. I appreciate the introduction, very kind. I'm happy to be here. I'll be talking today, as Heather was saying, about healthy aging in a digital world from the perspective of some previous work that we've done, both as we went from Oregon Health Sciences University to NIH and NSF onward to Northeastern University, and now have the privilege of working with Heather and others at Davis as a visiting professor. So I first wanted to start off with why we really desperately need new models of healthcare. There's a rapidly growing aging demographic, ever-rising healthcare costs, healthcare disparities, but there's so many opportunities we have. Ubiquitous mobile technologies have opened up the world for many advances relating to healthcare. Sensors have improved, they're smaller, cheaper, the batteries are better, we can wear them unobtrusively, and finally, many advances in computational modeling and big data approaches. So first, as a little more motivation, why it's important to bring this type of healthcare to the home. If you notice from this graph on the left, health behaviors account for the vast majority of influences. In this case, it's talking about premature mortality, but also morbidity, healthcare, the quality of life. In this case, 40% is attributed to behaviors, and helping people make changes in their health behaviors is very challenging. And we want to today explore how technology can facilitate interventions that are scalable and effectiveness. They can improve the timeliness of intervening, tailoring to individuals, and extending the reach of healthcare professionals and coaches. So there's so many opportunities we have in looking at exercise, sleep, socialization, improving medication management, cognition, safety issues, and stress or mood management. The idea here is to monitor with sensor data, make computational inferences, and then actually intervene as a coach would. So the opportunities we have in computational modeling come from simply looking at the streaming data from unobtrusive sensors. And I'll start with some examples on assessing activities of daily living and then move to cognitive monitoring. Then secondly, in the talk, we'll look at how we can also make assessments through more interactive systems. Finally, working toward then the actual intervention, where the computational modeling contributions come in dynamic modeling of patient state, context, and then leading to how best to intervene with health coaching interventions for health behavior change. So first, just a little quick review of what opportunities we have with sensors that are commercially available. And this is improving on a monthly basis. You'll see that new wearables are coming out, new ideas on smaller, more long-lasting, less obtrusive types of sensor opportunities. So within these kinds of watches or rings, you'll have accelerometers, gyroscopes. They can measure activity level, heart rate, electrodermal activity. Some now even measure oxygen saturation. Temperature is another one. Electrodermal activity, skin conductance is important for monitoring stress. So these are some of the opportunities you get from simple wrist-worn or ring devices. There's also wearables and clothing, glucose monitoring with a tattoo-like type of sensor. There's sensors that you'll see in shoes for gait measurement, and as well brain-computer interfaces. There's also opportunities for socialization and robots in the home or in nursing homes. WeThings is a typical type of opportunity for blood pressure cuffs, weight scales, which is very important for heart failure monitoring. Then even toothbrushes have embedded sensors. So it's important to even think about phones themselves. There's so many sensors in phones that are now very ubiquitous, even for low income and minority populations. Phones have become a very important type of sensor that we can take advantage of in trying to make inferences on health behaviors. There's a gyroscope, accelerometers, GPS is embedded in the phone. Light levels can give information on sleep quality. The camera can help with ECG, pulse, oxygen saturation, even mood with facial recognition. There's a microphone where you can measure voice affect, slurred speech, slowing, depression information, as well as temperature. So we'll, I'm going backwards, sorry. So forward, all of these types of sensors can play into the type of health coaching platform that can actually intervene based on data and inferences about the individual user that can help both the caregiver, the family, clinicians, as well as integrating the patients themselves into the care team. So I'm going to start with just what can be done looking at streaming data from unobtrusive sensors. And I'll start with examples of activities of daily living. This is work from Misha Pavel that just with simple motion sensors that are set up in a home, you're able to make inferences about legitimate pathways without needing to have an architectural model of the home or the apartment, studio, whatever. You'll know where there are legitimate pathways, can make inferences about which is the kitchen, which is the bedroom, and understanding sleep, as well as other activities of daily living. Now, this is an example of data that can be collected and is very informative simply based on motion sensors in different rooms in the home. And I just want to use this as an example of how important it is to be able to obtain simple data and make as many inferences as possible. As you then fuse it with other information you can get from the patient themselves or additional sensors. In this case, there are motion sensors in the bedroom, bathroom, living room, front door, and kitchen, as shown on the right side, color coding. This is for one individual living in her home over a year, where day one starts in the center and moving out toward the end, midnight at top, noon at the bottom. You'll notice this person goes to sleep not very reliably at any particular time, but around 11 p.m., wakes up around 7 a.m., and has very good sleep quality, not a lot of motion in the first half of the year, but for some reason, sleep quality is more disturbed in the second half of the year. She's in the kitchen around breakfast time, lunch, and sporadically at dinner. And it's interesting to note that if you were trying to develop safety algorithms and wanted to have a good alerting mechanism, you would have to be looking at this type of data to know the normal variability and take that into account when trying to make a safety alert. Now, comparing to a different individual, again, day one in the center, end of the year at the outer rim, this person has much poorer sleep quality, wakes up very reliably, is in the bathroom right at 7 a.m., preparing to go out. In this case, this person lives in a residential facility where they serve meals. And so there is good socialization. She's getting out every breakfast, lunch, and dinner. Doesn't have a set bedtime, but a very reliable wake time. So again, you would have to have individualized understanding of normal variability in sleep and wake in order to be able to be making reliable alerting. So again, these types of sensors, in this case, with a more narrow field of view, can be used for measuring walking speed, which is a very standard cognitive measure in neuropsychological assessments. So again, what can we extract as information from a simple measure of walking speed as the person moves through a hallway? And of course, there's context differences, but when you make multiple measures over and over again, you can monitor, extract the features, and model the parameters of walking. So this type of data, and this is a probability density plot here, where speed of walking in velocity centimeters per second is on the ordinate, and the abscissa is time over a couple of years. You'll notice that the warm colors are the peaks of the distribution. So this person starts out nearly 80 centimeters per second, but has a gradual decline, which is associated with onset of dementia. And they are diagnosed at this point professionally with mild cognitive impairment. But you'll notice we could have predicted the decline much, much earlier, like a year in advance. Similarly, there should have been another example. There were stroke episodes that could be detected. Now, for motoric cognitive risk factors, again, associated with dementia, you can see that in this case, healthy on the blue line, the green is self-reportive cognitive complaints, slower gait is yellow, and the purple is the mild cognitive impairment or motoric cognitive risk. And that later on in follow-up over the years will predict cognitive decline very reliably, just as reliably as many of the other standard paper-based neuropsychological tests. So this is the other example of detecting stroke, where you can see that there's a recovery in walking speed here after a stroke incident, but undetected similar events prior to this. So a simple measure only of motion sensors being able to detect walking speed can be extremely informative, especially when you're able to then combine it with information from other sources. So an example of other sources, some work that we've done on this, another motor test in a standard neuropsychological assessment is the finger tapping that you'll see in the upper right. It's just a test of how quickly someone can tap their finger. And that can be inferred from keyboard interactions. And so finger tapping, in this case, has very close correlation with the computer use that we've seen. Another measure of motor speed that's an opportunity, if you ever can get data from a mouse device, when people use a mouse, there's typically a mixture. This is a sample of one patient. On the right, the graph, you'll see very slow movements on the left, but it usually separates into active moves of the mouse where you have a very decisive type of move to a location. And it's that speed that correlates very well with the trail making test, which is a very important standard we'll talk about in a minute when we get to games, computer games that are designed to replicate this important neuropsychological test. So there's so many examples that you can extract from existing use, for example, linguistic analysis when people use the computer or even the phone, just measuring the complexity of their text can give an early detection of cognitive decline. The example I give here, Iris Murdoch, was a very famous author who died of Alzheimer's disease, or died with Alzheimer's disease, but her writings, they were not really influenced by editors as much as other authors. We could see, even though the final novels were very well received, there was a decline in complexity. And people that are very talented, highly educated, it's not easy to pick up the neuropsychological declines when you're comparing them to the population. But in her case, we could have predicted a cognitive problem much earlier just through linguistic analysis. That's also been shown to be diagnostic in schizophrenia and depression. Voice analysis from the phone can give information on depression and Parkinson's. You can think about movement. It's been associated, especially for bipolar patients, just simple activity, how far you are from home, how often you socialize, which can be inferred. It's not definitive measure, but these kinds of inferences, when they're compared to the own individual, can be very informative. So I just want to emphasize that this type of monitoring data can be very useful in managing neurological conditions, thinking about how successful your treatments are, medication or whatever intervention for cognition. If you measure it over time with an individual, a recovery from stroke or traumatic brain injury, or even just simple detection of early cognitive decline. And the benefits are, when you look at within subject trends, or additionally, the variability in this type of data is another independent indicator of cognitive problems. Looking for changes within subjects can be very important clinically. So I'm going to move on to the next type of source of information that will ultimately help in managing and intervening in the home. And this is assessments we can make through interactive systems. And I'm going to start, there'll be two examples. One is cognitive assessment through adaptive cognitive computer games. And as well, you can do the same with interactive video exercise. So Early on in our early work at Oregon Health Sciences University, we were able to work on a grant where we could develop adaptive cognitive computer games. And we were specifically targeting older adults. It was important that they were casual games. People already basically knew how to play them and were already having been shown to be very engaging. So the first example is a very simple, called On the Flip Side here, but it is a memory game similar to concentration or the game memory, where it's very simple. You can adapt the number of cards and the idea is to match. And as when you have a match, it removes it from play. Here we had the ability to model how well somebody could play with respect to their own previous performance. And so the model would be the time to make the decision, the speed, the motor response, and then having a model of forgetting, which needed to take into chance performance. And the idea was the model of forgetting could be represented very simply by looking at the number of intervening cards and having a Weibull survival function to give an estimate of the forgetting or memory buffer length. Another type of game was designed to measure divided attention. Divided attention is usually one of the first types of cognitive performance or cognitive function that declines with aging or with dementia. And so here it was a two-dimensional blackjack game, and it was not designed to measure how well somebody could play blackjack, but through the play and changing the difficulty, we were able to look at how well somebody could both play rows and columns at the very same time and divide their attention between performance on rows and columns. Finally, a very successful game in adapting to the trail making test, which is a test where you normally have to, on paper and pencil, first connect dots 1, 2, 3, 4, just simple numbers, and then secondly have to then in sequence move from numbers to letters. So you go 1A, 2B, 3C. Here we had a game that could change the complexity of that and be able to change the target string that you'll see at the top and measure how quickly and successfully somebody could go B2, A1. In this case, again, there's an embedded model where we look at the complexity of the string and their ability to recall the next target, which is represented in T sub R, search for the target, and that depends on N, the number of targets, and D, the number of distractors, so that you get a T sub S for search time, and then the simple motor speed of moving to the target. And so each of these parameters would change, depend on the complexity of the string and target. And the interesting thing we were able to show is that for Trails A, we compared the results of this game, the modeled trail making score, with the measured trail making score on the standard neuropsychological test. And the circles represent the easier, simple Trails A, which is 1, 2, 3, 4. And the pluses represent Trails B, where you had to set switch and change from 1A to B. The type of correlation that you see here is comparable to just simple repeating of the same test. So we were able to model how well somebody would do, predicting how well they would do with a standard neuropsychological test. And these standard tests can only be given every 6 months because of the learning issues. And people are typically only assessed once a year even. Whereas with this type of interactive system in the home with frequent play, we're able to look at trends and variability in these cognitive metrics. And when you're able to combine this with the other types of cognitive motor speed measures, you can get a lot of information that can be important clinically, both for screening, but also for managing the effects of a cognitive health intervention. So lastly, what I'm going to cover now are other opportunities for computational modeling. We've talked about the simple data from motion sensors, moving towards interactive systems. And now, what can we do to model patient state and context dynamically in order to help with health coaching interventions to the home? And so even with cognitive interventions, we need to, in order to generalize but beyond a trained task, we need to have a multifaceted type of set of interventions. And I think what's important here is that the physical exercise is going to be part of almost any disease management approach. And older adults typically have at least 2 types of chronic conditions that need behavior change interventions in the home. So it's important to have a infrastructure framework that will allow us to use technology, but based on known coaching principles. So I'll go through a couple of examples that we were able to work on with our new coach, Northeastern coaching platform. And so the important part here, in order the framework, it's important for the computational modeling of dynamic patient state. So the idea again, sensor data from the individual goes in through continuous monitoring, through the inference algorithms, and it's important to feed that information back to the individual in a timely way and tailored manner, but also including caregiver, family, and clinician responses. So in doing this, it's important to recognize that most health interventions are lifestyle interventions. They do require remote, just-in-time, continuous care, in contrast with examples that bring them to a clinic at unusual times, not when when needed. That feedback is really needed necessarily. So these types of interventions can make use of lower cost personnel that are more targetedly trained to motivate people to change their health behaviors. Standard clinicians are not trained in coaching the same way, but it's important to also integrate family and informal caregivers into the health team with roles, responsibilities. They're highly motivated. It's an untapped resource. And so we'll describe a platform for being able to do this. We make wise use of face-to-face time, video time, phone interactions. It's important to build rapport and have careful assessment at some times, and others can be semi-automated. So in doing this, we have a framework for a coaching system that first takes intake assessment, goals, barriers, readiness to change. These are all important variables in a health coaching platform. Makes use of a dynamic user model that then will be influenced by the monitoring data coming in from the home, the self-report data, typically very frequent assessments, end of day assessments, and update based on adherence to goals, the new barriers, goals, motivations, and this will allow us to then tailor the message and draw from a standard message database to tailor the greetings, closing, the feedback, and link to the coach, participant, and the family. And basically the underlying assessment provides a tailored action plan for each individual. So one of the types of interfaces that we've tested for communicating with both the patient and informal caregivers is to have our set of interventions that are important for almost all older adults and give feedback. In this case, this type of display would show that sleep quality, there's a warning, not urgent, but there is an urgent warning on medication. The medication needs immediate attention. Cognition is fine. Goals are 50% complete, and then access to the calendar. By clicking on any one of these, you get into more detail. So we've tested out many of these types of interventions in our home lab, and UC Davis and Heather's group has a very nice, a really beautiful smart home lab at Davis as well. And these kinds of places are useful for testing out interventions, both for visioning kinds of brainstorming ideas, but also getting most of the kinks worked out in new sensors, new ways of interacting with the individuals in the home, and doing usability testing, quality assurance, and training is another area that's important to think about, both training for clinicians and for informal caregivers. So we've already talked about interactive computer games. We've had other examples of projects in interactive video exercise, medication management, sleep management that I'll talk about a little more. Socialization is another important area. First, with interactive video exercise. As I was saying before, this is important in almost every disease management approach or any kind of wellness program for individuals. We've looked, and this was actually with Ruzhana Baichi, who was previous CITRIS director, and it was an NSF project we worked on with her, where we had chair exercises for older adults. And you'll see on the right, the physical therapist that we had leading the exercise. There was a lot of video content that would be tailored to the individual, and based on a Connect camera feedback in the skeleton image that you would see on the lower right here, we were able to make measurements of strength, endurance, flexibility, but also just simple, successful repeats of an exercise and be able to count repetitions and ensure that somebody was doing the exercise correctly. Following this work at Northeastern, we wanted to have exercise systems that were adapted to minority populations and different cultures. We investigated avatar interactions as well as the many YouTube videos that are out there, and collections where the engaging music and having specific matching to cultures. We were doing testing that could show that it's important to have this ability to adapt and keep people engaged. For medication management, this is another important area. Almost all older adults are on, typically 5 to 7 different medications. In this case, we put a webcam under a standard medication dispenser and allowed family members, remote family members, to be able to help with the dispensing process. There are many examples out there now of reminding systems for medication, but they rarely have the feedback and the actual dispensing of medications correctly is never addressed very well. So in this case, we could do both dispensing help remotely, but also ensuring that the medications were taken appropriately and having a quick intervention that could be facilitated. And we had family members involved as the people helping with this. Now, sleep, there's so many advances now in moving from the very expensive clinic-based sleep assessments overnight in an unfamiliar location with sensors all over. Now there's bed mats, even many of the wrist devices have been successful in this, being able to address, get fairly good quality information about sleep. And again, even if it's not perfect, it's measured frequently in a natural setting, giving immediate feedback to people the next day, how well you slept, the time it took to fall asleep, number of times out of bed, a restlessness, and a stress recovery score, looking at heart rate variability. There's a lot of advantages to looking at within subject trends, giving feedback immediately, and relating it to the action plan for sleep, whether it's sleep hygiene issues, anxiety that you may have been trying to treat with relaxation techniques. You can look and see if it's successful and then move on to the next, if not. Socialization is really important in health and often overlooked by standard medical care. Socialization's on par with smoking as a health hazard. So early on, we worked with Skype software now, and this was a secure system, but we then had the double robot that moved into homes. And now we're looking at a TEMI robot in nursing homes that is self-navigating, can move from room to room. It has a solo emotion classifier. And the idea is that a family member can schedule a visit with their loved one without having to bother the nurse and the staff at the nursing home, which currently, especially under COVID, is a real barrier. They have to go with a tablet and actually sit with the person for the whole visit. This alleviates the need. The family member can schedule the visit independently. And when the resident on the right, you'll see, can open the room door and sees the family member on the robot, can choose to sit and interact with the system. There's also, in this case, we're including music that's been tailored to the individual, having pictures, games that can help with the visit and keeping it fresh. Finally, one of the last most recent types of projects that we've had has to do with monitoring stress. And we do this with heart rate variability from wrist devices that give some information on that. And some also have the ability to get galvanic skin response, or what's called electrodermal activity. It's like what you would see with a lie detector test. And a third type of information that we've explored a bit is looking at voice affect that you could get independently from the home. But a lot of the work, and one of our PhD students has put a lot of work into how to visually give feedback to someone so that then you can say what types of activities seem to precipitate a particular stress. In this case, you know, as somebody goes from home to school, taking the exam, and then you'll notice that stress pops up again, visiting one other particular home location, and then of course declines at night. that type of feedback can be helpful in developing an introspection on how to move forward with stress and relaxation techniques. So as I wind up, just wanted to give an idea of the benefits of moving toward technology in this case. You need a scalable approach to delivering healthcare to the home. So technology is very important in extending the reach of clinicians, incorporating family and patients into the care team, providing timely, tailored, and continuous information to the individuals with an overall aim of improving quality of life while reducing costs. So there are informatics challenges in doing this. We've looked at role-based protocols for data sharing, and we found with older adults, it's not obvious exactly how best to do this. Quite often there will be one adult child that they want to share the data with, whereas others they don't. Data privacy and security is, again, a moving target, very important that the work that's going on in keeping data secure. We need modular approaches that are sensor agnostic. You'll see new sensors coming out all the time. Building a system for just one sensor, it can get you into a lot of trouble. We've had in mid-project sensors, people go out of business. Even somebody big like Microsoft, we were relying on the Microsoft band. Things change rapidly. It's important to have hooks that allow you to have a modular approach here. Battery life is another interesting issue. People, if you take off your device to charge it repeatedly or at unexpected times without a reminder to get it back on, many of these devices are not used more than 2 weeks. We've had a project with NSF where we're developing a ring to have embedded computational algorithms to do dynamic power saving and only use sensors and transfer data when needed. It's important to do further work on these dynamic models of patient state and to include context to get better accuracy. Then the last two here, integrating principles of health behavior change is critically important. We need to take what we know about how to help people change behaviors. It's very challenging, especially something like smoking cessation. It's important to be there at the time with technology when they need the help, and further techniques to generate these tailored and just-in-time messages. But for true personal health care, it's important to integrate the patient preferences, their social circumstances, their social support networks into this type of dynamic model for true precision healthcare. So just to summarize now, I want to make sure that I've left you with the impression that health behavior change is really key to improving health outcomes. If you remember, it superseded access to medical care, even genetics, social circumstances, and yet standard medical care is not putting the emphasis that it should on this area. A lot of that has to do with business models and the challenges we have in how we currently reimburse medical care. It's important to notice that most of healthcare actually is happening in the home. And this type of technology and computational modeling is going to be important in facilitating some scalable solution. We need a standard framework for health coaching interventions. And I hope it's been clear that how much data and opportunity there is for monitoring in a home environment with repeated measures that will allow us to have within subject trends much more reliably, providing earlier detection and feedback on any interventions. So tailoring, just in time, those are two of the biggest issues that have been shown to predict success with these types of health interventions to the home. But finally, whatever solutions we have need to be cost effective and scalable to actually have an uptake. I want to make sure to thank the people that have been involved in this work with us, ranging from Misha Pavel and our project managers, research assistants, postdocs, and PhD students, all been very helpful. So I think now's a good time for questions. And I'll just leave my contact information quickly and stop sharing.
Thank you, Holly, so much. And your contact information is also in the chat, so people can get it from there. I so appreciate your presentation, and I've always admired your ability to turn practical day-to-day activities into meaningful information that we can actually use to understand and manage health conditions, and older adults can use to improve their health. So thank you for that. We've had some really good questions put into the chat, so I'm going to pose a couple to you now. There were some questions about data privacy and security, and you answered them 2 slides ago. So I think we're covered with that, but that was an interest from your audience around data privacy and security. There's also a comment that tools are only useful if people actually are willing to use them. And we hear a lot about these days, digital divide, user-centered design, and just the acceptability to older adults. Can you talk a little bit about that and how you work with older adults to assure they actually use what you developed?
Yeah, it's so important. And I just want to emphasize how things have changed in the time that I've been working in this field. Mobile phones have become ubiquitous. If we can rely on what people already have, and so many sensors are out in the homes, but getting people to wear things that need to be recharged has been a critical barrier. And also designing for older adults, usability is so key. We spend in every one of our projects a lot of time on usability testing. And I think another key issue that you can do when you're in a study, you can monitor when people are wearing a device, give them reminders, find out what's technically wrong early on, immediately. It's almost as important as collecting the actual physiological data or behavior data, and getting making sure that you understand the technical problems immediately. It's one of the reasons that we worked and had a proposal to NSF on battery life. We didn't want to work on batteries, but we could use computational modeling to be able to use the opportunity to transfer data wisely, or how much to put on the actual integrated circuit that could be done locally. We had one engineer working on extracting energy from just room light, and so they would never have to take the ring off. So there are advances happening here. If something's comfortable, waterproof, never has to be taken off, you have one opportunity. But the other way to get people to keep using a device is to give them useful information and make them want to do it. If it's a burden and they don't care about the information, it's not going to last long. And I think the final thing I would mention about designing for older adults is they don't want something that makes them look old. Having a pendant, I fall and I can't get up, is a real negative. They don't want to show that off. They want to appear young and use what other people are using. So we've often found that when we design for older adults, we make it more accessible for everyone. We're usually thinking about ease of use. And that's a problem in almost all technology. So it is a very, very important issue that has to be addressed in every single project.
Thank you. Related to that, when you're measuring in the home and you're doing this quite a lot with your work, how do you distinguish if there's more than one person in the home, or there are dogs running around, or other beings that are going to trigger your monitors? How do you deal with that?
That's a great question, because that has been quite a barrier in early studies. We simply would only take people that lived alone because of that challenge. You can have, some people have addressed this with infrared devices or mats, where if people weigh differently from one another or have different body types. When we were doing bed weight measurements, we need to figure out when the dog jumped on the bed, or when there was an extra book, or these are, each one of these kinds of problems can be tricky. We've done some algorithms on visitor detection. One solution is not to measure when there's multiple, when it's confusing. You'll know that when you're measuring continuously, you have the opportunity to throw up your hands algorithmically and say, let's just not include this data since it's possibly contaminated. Also, in our computer games, we noticed sudden jumps in performance when the grandmother would let her grandson play. Or, there's all kinds of issues that do come up, and to the best of our ability, we always try to have algorithms that will detect these things. And it's absolutely important to, if you're having sensors in the home, like the motion sensors, that who's who, without forcing them to wear, you can have RFID if they're wearing different things, but if you can't rely on that, it's challenging. Good question.
You also piqued some interest around robots. So can someone refuse a visit if a robot knocks? And what do you know about the effectiveness of robots and how that works in terms of interaction and its quality for outcomes?
This is a whole new area for us. We did, some more anecdotal results with the early work with the double robots in the homes. People loved it, but we didn't get a firm study on that. And the current work right now is just starting in the nursing homes, where we first are deploying these self-navigating robots to get the residents used to having them. So they'll first wander through the halls every morning. That's been done, playing wake-up music that will get people in a good mood, supposedly. That's been fairly successful, just using robots in that way. But allowing for individuals, the family members, especially during COVID times, or just in general, when it's inconvenient to get to the nursing home, allowing them to connect in a meaningful way without an extra burden to the nursing home staff has been seen as a great need. But there's data on a lot of different types of robots, especially from Japan, with older adults in improving mood. And there's robots that will help people with disabilities be able to maintain their activities of daily living. So it's been a little spotty as far as results because it's so task dependent.
Yeah. There's a comment about just the preparation of dietitians and nutritional professionals in coaching, that they are highly trained, and in response to your comment that clinicians tend to not be. So there's a suggestion around inclusion there that I think is important to think about. Yeah.
Yes.
I have one more question for you, and then we'll close for the day. This is about what have you found that are the optimal methods for obtaining input from individuals and their preferences as you customize your technology? What's your best way of getting that information, eliciting it and using it?
I really like that question because I think this is sort of an important discovery that we've had, that we want to build rapport. We want to start out with either face-to-face or a video connection with a person in the home and the caregivers so that they know there's a person behind the intervention or a suite of interventions, somebody that really cares about them. And so and quite often we found that standard surveys, for example, if we're trying to find out their current physical abilities so that we can design an action plan that's appropriate for them, so much is missing and answered inappropriately in a standard paper survey. There's times when you start a new intervention that you want to understand the context of their home situation and be very careful about the assessment, whereas others can be quite automated. And then as you continue forward, have an understanding of when you need to jump in, have meaningful contact, especially if they've stopped wearing a device or they've stopped responding, that you move quickly and with a more personal touch.
Holly, thank you. You have kicked off the series beautifully for us, for CITRIS. On behalf of everyone who attended today and all the people who will listen to the recording later, I want to thank you for being here. Thank you, CITRIS, for the sponsorship, and I hope you all have a really great day. Thanks for being here today.
Thank you. Thanks, everybody. Bye.
Bye.